Hello, everyone. My name's Solome Tibabu. I'm the host of Going Digital Behavioral Health Tech, and I'm really looking forward to this conversation around asynchronous therapy with Talkspace. Thank you so much, panelists, for joining. We're going to be talking about a lot of amazing research that you have. This is also a follow-up on a conversation we did earlier this month. So we'll go ahead and drop the link in the chat during the conference and in the notes that folks can follow up if you didn't have a chance to see that. But before we dive in, we'd love to do a quick intro. So why don't we start with Dr. Choudhary, Dr. Hull, and then Pablo, if you can do a quick introduction around your roles at the company.
Thank you, Salome, and thank you for having us today. Varun Choudhary, I'm the Chief Medical Officer for Talkspace.
And I'm Derrick Hull, I'm the Research Director at Talkspace.
And hi, everybody. Pablo McCabe, LCSW and SVP of Healthcare Strategy and Accounts.
Thanks. So, Dr. Hull, without further ado, would love to jump in and learn about all of the amazing research that you've done in this space. I know a lot of people have questions around asynchronous therapy. Why don't you take it away?
You bet. Happy to, Salome. Although, Pablo, I don't know if you want to speak to some of the different offerings that we have at Talkspace before I speak more to async particularly.
Sure. Why don't we get started? So Talkspace offers what I call 4 pillars of service. And the first pillar would be therapy. We offer therapy to 13 and up. And that is through asynchronous, what Dr. Hull is going to be talking about. And asynchronous is better known as messaging therapy, audio, and visual. And then we also offer synchronous, which is live video sessions or live chat. And anyone can schedule those with a therapist as they enter the platform. We also offer a second pillar is psychiatry, and we added this service a couple of years ago. And so we really have a platform that allows for therapy and psychiatry, right? So mild to moderate folks can really get their services here, and psychiatry services are offered 18 and up, and that is only live video. And then there is exercises and tools, and these are really short, self-guided tools that people can use once they enter the platform, and even after they finish therapy or psychiatry, they're able to access these exercises, cognitive exercises, meditative exercises, ranging anywhere from 2 minutes to 15 minutes to allow a user to reflect on helpful skills. So really teaching folks to get to self-care. And then we have self-guided tools, and this is really with emotional intelligence in mind and helping somebody to really navigate relationships in the complicated road that can be these days, whether it's with a loved one, a spouse, as a parent, also with your colleagues at work. Don't forget, we spend at least 2/3 of our lives with the folks we work with. So navigating all these relationships can be tough. And these self-guided tools also allow for interactive group topical seminars guided by a licensed clinician. So when you take all of these 4 pillars, Derrick, they really allow somebody to maximize how to address their mental health needs. Derrick, I'll switch it back to you, though, to really concentrate on asynchronous and how Talkspace got started.
Great. Yeah. Thank you. So the focus on asynchronous today is largely due to 10 years ago when we started working through asynchronous messaging. The benefits of that primarily were to offer individuals more options for receiving care, to try to combat any barriers to scheduling or to travel or to other things that would make it difficult for somebody to keep a more traditional sort of weekly telehealth session. And the initial feasibility and acceptability research on this, just to see how much people enjoyed it, how convenient was it really, how effective did they feel it was very, very promising. And this kicked off a whole host of other research projects, because one of the things that we really wanted to understand was, if an individual opts for asynchronous message-based care, are there any trade-offs that they might want to know about before they make that decision? Is there going to be a trade-off in terms of outcome? Is there going to be a trade-off in terms of engagement in this mode of care? And so very early on, we started to release outcome measures over time so that we could get a sense of how people are responding to care. in terms of symptom reduction and other kinds of beneficial outcomes. And then we were very closely tracking and monitoring engagement. What kinds of patterns do people deploy when they're using this kind of care? And interestingly, we also did some early investigations into what was this experience like for providers. Daily message-based care is a different sort of pattern and mode than what we would expect on a weekly session-based mode of care. And early indications on the provider side as well suggested that there were some unexpected benefits to daily messaging. And I'll mention one, and then I'll dive in and do a quick recap of the data. One of the things that I found most interesting as we were talking to providers was the sense that they had greater access to the day-to-day changes that they were seeing in their clients. So whereas, say, like in a weekly session, you're relying on the client's memory, things that may have happened a couple days ago that maybe aren't so, fresh for the client. With messaging, they were starting to experience that in more real time. And so they have a much better sense of the ebb and flow of what's going on for their clients. And to this end, one of the areas that we particularly focused on was depression and anxiety. How well does asynchronous message-based care work for depression and anxiety? And this was a very large study, many years in the making, with nearly 11,000 individuals. And you can see the breakdown that characterizes these individuals. And importantly, if we look here at the graph on the left, we see moderate symptoms for depression and anxiety on average. Of course, there are folks who were much higher and folks who are somewhat lower. But on average, we see about almost 14 points, which, as I mentioned, is moderate for these two conditions, both depression and anxiety. And we see sustained improvement over time, up to 12 weeks. So about a 3-month treatment course. On average, we see individuals engage with asynchronous care for almost 10 weeks, which, if you're familiar with other research in delivering psychotherapy, to have that as an average is very, very promising. And I think speaks to the convenience of this mode of care and the ability of individuals to sustain engagement in this kind of care for that period of time. Also worth pointing out that similar to more traditional types of care, the majority of individuals who seek care through asynchronous are women. We see that a good chunk are between the age of 26 and 35. However, there are folks who are older and there are folks who are younger. Individuals in their 60s and 70s, we found in recent research that's just coming out, engage in a very similar way to younger individuals. So there's no indication here that this is a poor fit for older cohorts. And then the other thing I want to highlight is that when we do this research, we set a very high standard for what we want to define as good outcome. And that standard is called clinically significant change. And it's defined by individuals who begin above a clinical threshold for these measures and who would be likely to be diagnosed for these conditions. Of course, we also have the diagnosis from the therapist that we confirm before including these individuals in the research. And then if they start above the clinical threshold, we want to see them end below the clinical threshold. In other words, they're very likely to no longer meet criteria for either depression or anxiety. And we see in these data that 48% would no longer meet criteria for anxiety at the end of care, and 53% for depression, which is the PHQ-9 there. The other thing I'll mention is that you can add between 20 and 25% to each of those numbers for individuals who improved, which of course any improvement is beneficial for individuals, but didn't quite fall below that clinical threshold in the 12-week period. Although many folks continue on for past 12 weeks until they have the outcome that they like. Now, one thing that I want to highlight here real quick is if we wanted to understand predictors of outcome, particularly because we have a very granular sense of engagement through asynchronous care, because we know how many messages are being sent, we know how many words are in the messages. And one of the important predictors in this mode of care is the number of words that the client sends to their therapist. The more words that they send, the better their outcomes. And this is a critical finding because it's important to show that this mode of care has a kind of dose effect. The more you use the treatment, the better you are. Now, this is observational data for individuals using the platform for depression and anxiety. I want to talk quickly about observational data for PTSD. And by observational, I just mean these are individuals using the platform as normal. We're not doing any randomization. For PTSD, we broke the data out in a slightly different way here because we wanted to understand different kinds of outcomes You can see there's 4 different patterns of outcomes that people have. There's a group that stays relatively chronic at the top, and then we see 3 other groups who improve, some very rapidly and some a little more gradually through time. The important thing to highlight here, though, is that the majority of individuals seeking asynchronous message-based care for trauma, which is a difficult and debilitating condition, have good outcome. And the clinical threshold here is about a 33. So we see that a good chunk of these individuals finish below that threshold. Again, predominantly female, although more men in this sample than we saw with depression and anxiety. Age distribution is very similar. Education level very similar. And we also see similar predictors for outcome in the trauma population. More client messages or words sent to their therapist, again, turned up here. Another one that turned up, we found this in the depression and anxiety as well, though I didn't have it on the previous slide, that's critical, is that the closer one's relationship with one's therapist through asynchronous care, the better their outcome. And that's what's reflected here in higher therapeutic alliance. And we also see here that an individual's first time in therapy is predictive of a better outcome, along with education. Now, a question we might ask ourselves is, in conjunction with symptom reduction, do we see carry-on effects? In other words, as individuals improve from their anxiety and depression and other conditions, do we see improvement in their work-life balance, improvement in their productivity, improvement in their quality of life? So we ran this study to confirm that there is a connection between these 2 things. And here we can see significant improvement, again, in both anxiety and depression. And I should mention as well that I'm only covering a handful of our studies here. We have 7 or 8 studies that focus on quality and clinical outcomes. And we've also done over a dozen case studies for some of our partners. And we find that these results I'm sharing with you today are extremely robust across populations and across different kinds of user groups. So in addition to the symptom reduction that I mentioned here and that we've seen repeatedly, we also see a 56% increase in work productivity, a 67%, which is huge, increase in employee activities outside of work. So this is the ability to have work-life balance, to sort of leave work at work, engage with your family, engage with pleasurable and recreational activities outside of work. And we also saw a 50% decrease in the number of hours missed in work. Let me show a different representation of it here. So on the right, we see the decrease in hours missed, an increase in productivity, and an increase in work-life balance. Now, for those who are familiar with research, you may be asking yourself, look, the data that you shared so far are observational in nature. Maybe these are individuals who are particularly motivated to receive asynchronous care. So to answer that question, we wanted to run a randomized controlled or clinical trial. And in this study, we randomized individuals to either asynchronous care only or to video-based care only, a more kind of traditional telehealth approach. It's important that we randomized within therapists so that therapists have both messaging-only cases and video-only cases so that we don't have an imbalance of, say, therapist skill or background in these conditions. It's also critical to point out that the individuals that are randomized into this study were referred to us through a mental health advocacy organization. So these are not individuals who are seeking asynchronous message-based care, but instead are seeking any kind of treatment. And then when they come to us, as I mentioned, we randomize them to either messaging only or video only. Now, in this first pilot study with about 60 people, we found no difference in clinical outcome for depression and anxiety. We also found no difference in the relationship that they reported having with their therapist, which again is important because I think intuitively people tend to assume that if I'm working with a therapist through asynchronous care, I'm not going to have the same feel for them that I would if I were working with them by video. My relationship's not going to be as strong, but we did not see that in these data. We also saw an advantage to messaging for retention, 3-month retention. So they were 10% more likely to finish treatment in 3 months or to go the full 3 months and have a full treatment course, which again, I think speaks to the convenience of this medium. And we also saw a slight superiority effect for messaging only care here on a measure that tries to tackle or tries to capture, the real life effects of treatment. That pilot study enabled us to get funding through the National Institute of Mental Health to run a larger study. And these are phase 1 results. We're recruiting individuals into phase 2 now. In phase 1, this now is 215 participants focused on depression and anxiety, same design that I mentioned in the previous slide. And again, we replicated the finding that there's no difference in depression or anxiety scores or clinical outcomes for either of those two conditions between text and video. That there's strong reduction in symptoms, 50% reduction on average, which is a strong effect, which we would want to see. And again, we saw that messaging was slightly superior for longevity and retention. Now, this graph on the right, I want to highlight just a couple other things that stand out in this particular population. So the first is, if you look at baseline scores, remember before I mentioned that in our typical client base, we see an average baseline of about 13, 14, somewhere in there. Here, we're seeing an average of about 17. So this is a severe, moderately severe range. We see that both video and messaging are effective for individuals who begin at a more severe range for depression and anxiety. And as you follow the trend lines over time, you can see that, that the outcomes are identical between messaging and video. Let me say a little bit more about this sample. So other people also have questions about how does asynchronous messaging work for more diverse populations, both diverse in terms of their ethnic or racial background and diverse in terms of their economic background. And I think one of the intriguing things about the RCT findings that I've shared with you is that this user group is more diverse. There's more individuals from communities of color that are in this sample. We see no difference in outcome across these different backgrounds. And we also see that these individuals are somewhat economically vulnerable with an average yearly income of about $35,000. So this is a nice indication that asynchronous care can work for a variety of different populations and groups from a variety of different backgrounds. I'll go ahead and stop there, Salome, and thanks so much for your attention.
Thank you so much, Dr. Hall and Pablo. This is excellent research, and just the scale of your study is so impressive. I'd like to dig in a bit more. So how about first, Dr. Choudhary, could you talk to us about what kind of training do therapists receive for asynchronous therapy, and how does that process and content differ from video-based therapy?
Certainly. So we have a very comprehensive training program for our therapists, and it's broken down into two different arenas. You have the standard required mandated trainings that you have to do, and then we have a specific training on our platform. Within that platform training is where we really introduce them to how asynchronous is done on the platform, what it is, and how telehealth in general occurs, given that everything is remote. And so with live video sessions, it's a little different in that you're in the moment and you're seeing somebody face-to-face on a video conferencing camera like we are right now. With chat, it's going to be an adjustment. It's a little different for anyone who hasn't tried it before. But it's interesting because the learning curve is so high. Once people are exposed to it, it becomes like a second nature type activity, just like texting usually is with friends or family.
Great, thanks. And another question that I'm sure some of the employers and other audience members are wondering is, how do you measure work productivity and fewer missed hours? Do you track missed hours before or after treatment?
I'm going to focus on the real world aspect of that. I think for the research project, it was one way. But if you look at real world examples of this, first of all, the most important point to realize is this is it's choice. You get to choose what kind of modality for therapy that you want. With that, let's contrast that to traditional. So with the traditional therapy model, you drive to your therapist's office once a week. Who knows how long it takes one way. You're having to miss time from work or from your busy life. With asynchronous chat, the real value behind it is that it can be done any place, anytime, and it will be part of your workday or part of what's going on in your life. And it gives people the flexibility to get the treatment that they need when they need it. And from a therapist perspective, that also is very convenient because we do have independent contractors who have their own practices, but they're still on our platform because it gives them the ability to do chat-based therapy asynchronously with additional clientele.
Thanks. And Dr. Hall, I'd like to pivot back to you and ask a bit about the optimal dose for therapist interactions. Are any findings about that, or how does asynchronous care impact the retention rate through the course of care?
You bet. So, as we saw in the slides that I spoke to earlier, one of the things that is clear, and we've replicated it several times, is that asynchronous care does extend retention in treatment, increases the likelihood that you would go 3 months. And we also see, if we track it more quantitatively over time, that individuals in message-based care tend to stick with treatment longer than individuals in a more traditional weekly session-based model do. Speaking to the dose and optimal dose is challenging because there's so many individual differences that go into why an individual seeks care. Why are they seeking care now? What's the nature of the presentation that they bring to the clinician? Some individuals are struggling more with socioeconomic concerns in addition to psychological challenges. So there's a lot of variability. But I think a general rule of thumb that we can mention is that ideally, if you're working in asynchronous care, you want to try to message at least daily. We've seen that there's something about the frequency of engaging in this kind of care that's important, both in terms of, as I mentioned before, giving the clinician insight into what's going on for you, but then also as a way of working through your own process, keeping what's going on top of mind. It gives you more opportunities to process what's happening, what your therapist has shared with you or recommended to you. So that's a general rule of thumb that we like to see for dosage, is to really try to engage in it 5 days a week.
Thanks. And Pablo, you talked about the services that you offer at Talkspace. Can you tell us a little bit about the populations that Talkspace serves, and tell us a bit more about the employers, payers, EAPs that you serve and their needs in 2022?
Sure. Great question, Salome. So I think, many of us know Talkspace. 1 out of 3 Americans in a recent survey said they recognize the name Talkspace. And that's because we started over 10 years ago as a consumer-based platform. But then in around 2016, employer groups started to really see and desire the efficacy and an outlet that both Dr. Choudhary and Dr. Hull have spoken about, that async really allowed their employees and their dependents and spouses the ability to use async and access async in a way that really allowed them an outlet and connection to therapists that they weren't able to attain before. So employers adopted us, and about a year or so later, EAPs and payers looked to place us in their network so that people really had access to us through, 1, their employers, 2, their EAPs, and 3, a behavioral health network. And so Talkspace is unique in the sense it sits in network as an in-network provider, like a large group practice throughout the 50 states for both therapy and psychiatry. And so folks have different ways of accessing it. So we see various populations because we work within a number of the national EAPs and payers, as well as a number of the blues to provide these services. And within that really is a reflection of the employer groups from various industries, as well as folks just accessing ongoing therapy when they need through asynchronous or synchronous messaging or video. So we're really working with a diverse population, and we're able to work, again, just want to remind folks that we work on the therapeutic side with 13 and up, and on the psychiatric side with 18 and up. So really trying to address those needs of mild to moderate folks in various industries, various backgrounds, and various ages, as Dr. Hull showed.
It sounds like not only your study is large in scale, but also your reach and your providers, all 50 states.
Yeah, and Salome, you make one good point, and to really, I think the other important thing that we all forget to discuss is in this industry is what are we doing to enhance the experience and reach of the provider. And so in that, our providers are incredibly diverse. 35% identifies as working with LGBT community, almost 50% working with BIPOC, 45% with adolescents. So Also, I think what's important is we look to enhance the experience and the ability of the provider to reach their client, but we also actively look at who our populations are, and we recruit providers so that we allow for diversity in ethnicity, but also specialty, as well as seasoned clinicians in various backgrounds. So I think that's important, again, to highlight. Thanks.
Wonderful. Dr. Hall, I'd like to ask you something that I've been thinking about for a while. Do you have any hypotheses around potential reasons for why first-time therapy users have shown the most improvement?
Yeah, Salome, that's such an interesting question. And it's an area of research that we're continuing to explore. I mean, now that we've established a nice baseline for outcomes that are expectable for asynchronous care, we have a whole other research program that tries to understand exactly how it's working. What are the mechanisms of change? How do these mechanisms interact with the concerns that people bring? And one of them is first time in treatment. On average, we see anywhere from 45 to 55% of individuals who are pursuing asynchronous care. It's their first time seeking psychotherapy. An interesting finding that's reported in the literature outside of the research that we're doing, and this is, every time I say this, it just blows my mind. The statistic is insane, is that on average, individuals will wait anywhere from 8 to 9 years from the time that they start to sense that there's a problem until they're able to seek care. And we know that there's a whole host of access barriers that go into preventing them from seeking care more quickly, in addition to stigma, although I think that's starting to reduce for folks over time. And so one of the things that we think is going on with the bump and improvement for individuals seeking care for the first time is that these are folks who have been waiting to seek care. We know that asynchronous messaging does offer opportunities for new communities who otherwise have not had access to care. One of the particular findings that informs what I'm saying here is we did a comparison between individuals in urban settings and individuals in rural settings. And one of the contrasts we found there as well is that individuals in rural settings who traditionally don't have great access to care also had better outcomes. They felt a closer connection to their therapist. And we found this especially for individuals who reported barriers to accessing care in the past. And so one of the primary reasons we think is that first time in care, individuals finally have access to something they've needed for a long time. They felt isolated and alone. They felt like they haven't been able to access assistance and support. And now that they have that, the benefits to them are rapid and significant.
That's amazing. I have so many more questions, but as always, we run out of time too quickly. So if I could just pick one more, either Pablo, Dr. Hall, how does the effectiveness of asynchronous therapy compare to synchronous treatment, just to hit the point home?
Pablo, if it's okay, I'll speak to this one and then happy to have you to add on. As we saw in the research that I shared today, we see no difference in outcome between an asynchronous modality and a synchronous modality, more traditional kinds of telehealth. And I think that's surprising to folks because, again, we sort of think that there's something about the nature of messaging or text that maybe leaves important things out of the care delivery. Yet what we find is that there's no difference in clinical outcome. There's no difference in the relationship that individuals report between themselves and their therapist, between messaging and video-based care, which again is, I think, really remarkable and something that we're still working on trying to understand better. And then the third thing that we find is that message-based care, if anything, has a bump or an advantage in terms of retention and completing care over video-based care. And as I mentioned before, we think that's largely driven by the convenience and also the immediacy of that form of care. So very, very interesting and exciting research, and happy to share it with you today.
Thanks so much. I talk about this often, that we need to do something dramatically different to address the dire needs and demands for mental health support. And it's clear that your team has come up with something that's very creative and different, but also proven. So it's really exciting to learn about this today, and we'll include the links throughout the chat, throughout the conference. Thank you, each of you, for your time.